I'm so sorry to have to give this review in here, but so honest out of all the other rooms in the building book. Let's make the most of it, shall we? I can't believe anyone missed this. There's clearly ST elevation in leads V2 and V3 with no evidence of reciprocal changes, like ST depression or D-wave inversion, in the other leads. It has left axis deviation since lead 1 is positive and lead AVF is negative. Positive, negative, left. You must be able to show consistent flutter waves to call a rhythm atrial flutter. Although there is baseline artifact in AVL, which could be confused for flutter waves, they obviously are not, since the same baselines in AVF and lead 2 do not show it. If this was left ventricular hypertrophy by Sokolow criteria, then the S wave in V1 plus the R wave in V5 or V6 would have to be more than 35 little boxes, or 7 big boxes. To call it a bundle branch block, there must be a prolonged Q, or S. Even if you think the Q, or S may be prolonged, in this EKG there is no positive Q, or S in V1, so definitely not a right bundle branch block. So this is clearly ST elevation in leads V2 and V3 with no evidence of reciprocal changes. Is it an acute posterior infarct? An acute posterior infarct would have a pathologic initial R wave in V1 and ST depression in V1. Maybe it is an acute inferior infarct. An acute inferior infarct would have to have ST elevation in at least 2 of the leads, 2, 3, or AVF. I know. It's an acute lateral infarct. An acute lateral infarct would need ST elevation in lead 1 and AVL, or in V5 and V6. Well, then it must be an acute anteroseptal infarct. Yes, there is ST elevation in V1 through V4, with reciprocal changes in leads 2, 3 and AVF, so this is an acute anteroseptal infarct. I think this is definitely a left bundle branch block. No, although the QRS looks wide, there would have to be a large positive R wave in the terminal part of the Q, R, S in V1 for it to be an RBBB. Is it ventricular tachycardia? No, but it is good you are thinking of that with a wide complex rhythm. Look at V1 and lead 2 and you can see definite P waves, making it a supraventricular rhythm with a triple B. Oh, look at the lateral leads. It must be an acute lateral infarct, age undetermined. No, first there is no ST elevation, or pathologic Q waves in the lateral leads, 1, AVL, V5 and V6. And you cannot have both an acute and an age undetermined infarct unless you have both Q waves and ST elevation. I guess that means it must be a left axis deviation. Yes, lead 1 is positive, and lead AVF is negative. Positive, negative, left. Okay, I promise I will do better on the next one.
I am pretty certain this next one is a second-degree AV block, type 2.
Close, but this is a type 1 since it is irregular and drops a bit after the PR interval gets wider and wider.
So it isn't a third degree either.
Lizzie, I believe I just explained that it is a second degree, type 1 since it is irregular and drops a bit after the PR interval gets wider and wider.
Well, I don't really see an inferior infarct, age undetermined.
I concur. An age undetermined inferior infarct would have to have large, pathologic Q waves into the inferior leads, lead 2, lead 3 or AVF.
Well, there's obviously left atrial hypertrophy.
No. LAH would have to have a large terminal negative portion of the P wave in V1 or a wide, M-shaped P wave in lead 2. If anything, the P wave in V1 is mostly positive, not negative.
By process of elimination, I guess the correct answer must be normal axis.
Yes, right. But what makes it normal?
The QRS in leads 1 and AVF are both positive. Positive, positive, Normal axis. Bob, I hate to interrupt you while you are reading these old-fashioned things called books, but can you explain this EKG to me?
Of course, I was actually just heading back to the bathroom, where I have been holding a review class.
I'm pretty sure I should get credit for this. I called it a left bundle branch block.
If that is truly the case, then I'm pretty sure you should not get credit. To be an LBBB, there would have to be a wide QRS complex. There's absolutely no question in my mind that the QRS is narrow.
Oh, is that what I said? I meant that I put atrial fibrillation.
Well, then you are still gonna miss it, because it is way too regular to be atrial fib, and there are obvious uniform, upright P waves in lead 2.
Actually, I think I meant to say poor R wave progression.
Nope, keep trying. Poor R wave progression, most commonly due to an anterior infarct or LBBB, is when the R wave in V4 is still negative. This one has early R wave progression, but that is not poor R wave progression.
What about left ventricular hypertrophy?
I can see why you might think that. With a narrow QRS complex, so there is no bundle branch block, but the S in V1 plus the R in V5 or V6 does not add up to more than 35 little boxes, or 5 big boxes. So it doesn't meet so-called low criteria. And that's the only one we know right now.
Okay, well I guess that means it is left atrial hypertrophy.
Yes, you got it. You can clearly see the terminal negative portion of the P waves in V1 are bigger than the positive portions, and they hold water, meaning you can fit at least one small box inside each one. Now, can I please go back to the restroom so we can finish this review?
Bob, can I talk to you for a moment? I wanted to apologize for not being at the exam. I went north for the weekend and found some ice that I slipped on, suffering a severe whiplash and a concussion.
That's okay. I hope you feel better.
But what do I do about the exam?
Don't you worry. I will spend my weekend making you a makeup exam that you can take next week.
Oh, no. You don't need to do that. I called Ashley and she opened it up for me and I already took it. Can we go through it?
Yes, I'm on my way into the restroom where the rest of the class is doing a review.
Well, I only have one question about this one here. And I can't really move too well. Can we just go over it real quick?
Yes, as you can clearly see on this one, the underlying rhythm is way too regular to be atrial fibrillation. The QRS of the underlying rhythm is narrow, so you can't call left bundle branch block. Right ventricular hypertrophy would have a large R wave in V1, and there's ST depression and some T wave inversion in the anterior and lateral leads, so you don't call it an acute anterior infarct. That would require you to see ST elevation. Therefore, it must be anterolateral ST changes. See the ST depression in V2 through V5 and AVL. I'm back, Joe. Oh my gosh. What happened to you? We had a little disagreement while you were gone over the location and clinical significance of the Edinger-Westphal nucleus. It is totally inconceivable that the Edinger-Westphal nucleus would be controversial. What have you learned? I have learned that under absolutely no circumstance do you ever want to make Venus or Lisa mad. Whatever they say, you agree with them wholeheartedly. Additionally, never fight a land war in Asia. That is good to know. Now I challenge you to a battle of wits about this next EKG. Yes, with my one good eye, I can definitely tell that there is not an acute anterior infarct, since there is no ST elevation of 2 mm or more in leads V1 through V4. And lead 1 is positive, with AVF negative, so that is a left axis deviation, not right. Positive, negative, left. And finally, I can rule out all bundle branch blocks since the QRS complex is narrow. Therefore, the answer is obviously inferior infarct, age undetermined, since we see pathologic Q waves in leads 2, 3, and AVF. Very good, but I'm concerned you may have just guessed. I know you had to ultimately ask yourself, am I the sort of professor who would put the answer first? Now, a clever professor would put the answer at C because he would know that only a great fool would choose C. Since it is so well known that students without a clue usually choose C, I am not a great fool. So you can clearly not choose C, but you must have known I was not a great fool. You would have counted on it. So you could clearly not choose C, but I would know that you do not consider me a fool. Therefore not putting the correct answer at C, so you might think that knowing that you know what I know, you would choose C, but you would be incorrect following that logic, because I know you well enough to know that you would know what I knew and probably think I would hide the answer somewhere besides C. Therefore you ultimately chose C, the inferior infarct age undetermined. Well, Professor, you'd like to think that, wouldn't you? I failed to beat back Lisa and Venus, meaning I'm incredibly weak. But I have correctly given reasons for not choosing the other choices. You have fallen victim to one of the classic blunders made by professors. You assumed I did not know how to read an EKG, when in actual fact, all Sicilians named Shivo learned EKG interpretation at a young age. But Joe, it is you that has erred. You must learn that you should never go against a professor when your grade is on the line. Ha ha ha, I am no one to be trifled with.
Professor Bob, may I ask a question?
Yes, Natasha. I am always open to questions from the front and the back row. Since we are in the restroom, we will consider you to be in the front row. Proceed, please.
I do not want you to take this the wrong way, but if you keep giving this review in this manner with all of these mesmerizing little videos, then we may never get through it. Would you mind just narrating the rest of the review, being sure to make note of exactly what will be on the exam?
Inconceivable. Natasha, Natasha, Natasha. It hurts my tiny heart to think you guys would rather hear my obnoxious voice than to watch cute little vignettes in the restroom. Reviewing exams is like being a local fisherman out for a pleasure cruise at night in eel-infested waters.
Well, we do have other things to do with our life. You know.
Okay. Don't let my little discussion of what may end up being one of the most important skills you will need as a PA get in the way of your studying for pathophys or farm. It is not like you will have too many patients with hearts.